You have, oh goodness, what do I name this guy? Patrick Johnson, I think. Patrick Johnson is a 78-year-old guy. He's got a past medical history of hypertension, diabetes, deceased on a renal transplant in 2010, glaucoma, depression, and anxiety. He presented to the emergency room for 5 days of worsening dyspnea and a cough. They did COVID swabs on him, like 7 or 8 of them, they're all negative. I say that to you because this is not what you're looking for. The room is safe, this is not a pandemic, you know, this is COVID negative. Fair. Okay, and that is what you got. They did not give you much else in sign-ups, and what you did ask, the more questions you asked the ER, the more you could tell they were confused. And so you did the right thing, which is sometimes the right answer is to be like, okay, thank you very much, please send the patient. That's what you've done, which is the right call. So now the patient is here. They did mention to you that they were in the 70s on, when they first came in on room air, they put him on a non-rebreather. When they brought him back upstairs to you, for some reason, they couldn't transport on, there's some like uppity person who says, well, we couldn't transport on this thing, so he is as you see him.
Mr. Johnson, my name's Sarah. I'm one of the nurse practitioners. How are you doing?
Oh, hi, I'm good.
How are you feeling, Mr. Johnson?
Oh, just have this cough. I just can't catch my breath.
Let's go ahead and start him on a non-rebreather. Mr. Johnson, I'm just going to take a look at you, okay? Can you tell me where we are right now?
Yeah, we're in the same room.
Listening to lung sounds?
Feels a little bit coarse.
What's the motion on you, Mr. Johnson?
Kind of moderate throughout. Lung feels maybe right a little bit worse than that, but mostly diffuse throughout.
How does the right lower specifically sound?
Same. He's moving air on that right lower side. You hear a bit of bronchus, kind of, coarse sounds.
He's talking to us.
Yeah. Your cells came up a little bit, but I'm not reassured by that. Mr. Johnson, does it feel like you're working hard to breathe?
Oh, yeah.
Okay.
Yeah.
Let's go ahead and start bagging him.
Do you want to get an ABG, chest X-ray?
Yeah. I'd like to get a chest x-ray, please, an ABG, and then let's go ahead and send a BMP and a CBC as well. Yes, BMP.
This is the chest X-ray that they had from the emergency room.
Just sitting down.
Looks pretty diffuse throughout, maybe a little bit more consolidated in the lower right lobe. And you said he's been here for 7 days now?
No, he's been having shortness of breath for 5 days. But he just came into the emergency room this evening.
Okay.
So what about medications that he's on?
Salts are up to 93. Can we maybe call pharmacy and see what medications this guy's on?
So you call up the pharmacy. He has nothing in this pharmacy. He's never been seen before previously ever. His wife is here. He tells you. He's got this past medical history. He takes medicines for his high blood pressure. He takes medicines for his diabetes. He takes medicines for his kidney transplant. He takes some eye drops, and every now and then, he'll take his ibuprofen for some neck pain.
Okay.
Do you want to?
So given his white count and chest x-ray, I'm a bit concerned about infection. Maybe we could do some blood cultures and a sputum sample as part of our workup. What do you guys think?
Yeah, I think so. Do we want to take a look at him too?
Yeah, so I looked at the front of him and didn't see anything. Is that correct? We can go ahead and roll him to the side and take a look at the back. All right. 1, 2, 3.
Okay. And then, do we know what medications he's taken for his transplant?
I've got a list at home. I've got a list at home.
Okay.
I can go get it for you.
Okay.
Probably on like some immunosuppression,
Right.
pred and stuff like that, which increases my concern for an infection.
Do you want to ultrasound?
Yes. Do you have a blood? Start with the parasternal long.
I think it looks like it's
Does it look like?
hyperdynamic.
Yeah. And does he have some hypertrophy too? Not left ventricle. Okay. History of hypertension. Okay.
We'll switch.
Parasternal short.
Oh, yeah, he looks like really hyperdynamic. So we probably should give him some fluids. Did you send an ABG?
We did.
With a lactate
Yeah.
on it?
Is it too late to add a lactate to that? And then while I have this, I'm going to go ahead and take a look at it.
Yeah. And
Sorry.
I guess the thought, yeah,
Antibiotics too.
Mhm.
Get broad spectrum.
we'd have to consider, I mean, at some point antifungals if he's chronically immunosuppressed.
Yeah. So what do we want to do? Like zinc,
Okay,
Socin. Yeah.
They don't like the Vosin,
Medicine.
so.
Yeah, especially
Cef-
kidney transplant.
Cefepime.
Yeah. Okay.
Don't kill us.
So we could do like cefepime and then fluconazole to get fungal coverage.
And Vanco.
And zinc. Can look up the doses for that. I'm just gonna look at the. Just looking for one sliding.
So we start on some fluids, right? And
Yeah.
just do an assessment of
Oh,
IVC.
there's some lines back.
One slide on
So he
that
just
side.
looks super hypoxic. Do we want to maybe stop bagging and put him on BOPAP? Well,
You don't
I think he's got
it's
pneumonia,
infection.
but his pH looks okay. He's just really
You want to
hypoxic.
intubate
So his sats are coming down.
with bagging.
Yeah, with bagging. This guy's not a DNI, correct? Okay. I would like to move towards intubation unless anyone has some objections. Okay, let's go ahead and do we have our BNP back?
Yeah, I'll show it here in the reference, so we'll start putting it up.
Do we have a weight for this gentleman?
I think we'll just run into that.
One second, I got
Or
you.
actually,
You want to intubate?
sure.
Pressure still looks okay. Salt, but okay.
Heart
Mild
rate's been
tachycardic.
stable.
He is
Um,
142 pounds.
Okay.
Okay, so that's about
sorry, the,
65 kilos.
The math.
What would,
Right here?
I get it.
if you want to determine what
Yeah.
intubation doses you'd like. Okay, do we want to start some fluids? Working on intubation.
Yeah, you can give a liter of LR.
Yeah, let's go ahead and do a liter of LR or plasmolite, please.
LR or plasmolite?
We'll do plasmolite.
And you want that like to a pressure bag or on the pump at 999 or what would you like? Or is flowing?
Accommodate.
Maybe like 200 milliliters an hour.
200 an hour? Okay.
What do you guys think? I mean, his pressure's stable. I don't think we need to like
Yeah, I
put it
would do
all
it all.
in. Okay.
I went through it.
But at least have a pressure back standing by in case we completely lose all of our preload.
Okay. So,
And it couldn't hurt to have a backup Levo can too.
yeah, we can go ahead and have Levo in line just in case we need it. Okay, so we've done non-rebreather, we're preparing to intubate, chest x-ray, we've got an ABG, some other labs, infectious workup, we looked at him on ultrasound, running fluids.
We'll do 39 of rock, and this is 20. We did 0.3 times 65, so 20 of etomidate.
Okay, awesome. So we can go ahead and fill those out.
And I'm not as familiar with acute like rejection issues. I mean, his lactate's 2.1, which is mildly elevated in the setting of sepsis.
Can
I
we
don't know if
see-
that's a thought process.
Can we take a look at his liver enzymes?
They were normal.
Yeah. Nothing was jumping out at me, but okay.
So our stats are still in the 80s. Oh, we're discussing.
Yeah.
Nice.
So we've got everything optimized. We have medication doses ready.
We've got Levo ready to tank.
Yep, we got Levos just hanging ready to go if we need it.
What were the induction drugs I heard?
Etomidate and rock.
So our pressures are okay, so I think we can.
Like get your doses right.
Perfect, guys. Let's get the head of the bed ready.
And I'm gonna be your RT today. Okay. Just because that, the blade doesn't actually light up and it's very challenging, so.
Anesthesia is here. You're welcome.
Okay. Thank you for coming.
You're so welcome. You know, once every 6 months we show up. Switch review. Got it.
Just in case we need an oral airway or a nasal airway. We've got suction. We've got all of our equipment. Do we have a PEEP valve on there? Yeah. And then we've got a color flow valve. We've got our ET tube holder. And we have a 7.5 in case at some point he needs to be crossed. Okay,
Okay.
I think we're ready to proceed.
All right. So have we given our accommodate and rock?
Let's go ahead and push our drugs in. Looks like we have access on the right side.
So that is your Levo. But
Just leave it. This is okay.
yep, that's your free flow, or that's your 200 cc an hour.
You okay if I give them?
Yeah.
Okay. So we're gonna give induction medications now.
Okay.
Okay.
All right.
Yeah, we can just cycle another blood pressure thing.
Oh, this one is the one without the. Okay, so
Yeah, it
we're
didn't have a
blowing up the
balloon.
balloon. Okay. Pull this out. Pull this out. Okay.
So this is gonna connect to
To
oxygen.
the, yeah, so I would usually slide it on the top. There you go. And then we have the
Okay.
ET tube holder.
We're
Okay.
listening for breath sounds. Do we have good breath sounds?
Do we have color change?
You do have color change.
Okay. Looking at chest rise.
Rising.
Our vitals look stable. Let's go ahead and cycle one more pressure.
So
So what settings would you like me to put him on?
I would like to start with a rate of 16. How tall is our gentleman?
5'6".
so about 60 kilos. Let's do a tidal volume of 400. FiO2, let's start at 80. And then we'll say PEEP of 6. Sorry. And then can we send another ABG, please? Sats are up to 90, blood pressure and heart rate are stable.
So it looks like we have a primary oxygen problem. Do you want to increase the PEEP, maybe?
I think that's a good idea. Let's do PEEP of 10. Can you feel about that?
Yeah, we can look at the PEEP ladder.
Yeah.
Do you want the ABG on the 10?
Yes, please. Thank you. Okay, our sats are still. Does anyone have any recommendations?
If we're at 100%, our PEEP should be 18.
18. Okay.
And then we could get a post intubation x-ray, maybe check another ABG, and we're still not oxygenating very well.
Okay.
Our blood pressure, should we cycle another one of those?
So that I know when do we draw the image?
We drew it on 10 and 80. It's a 3.
Your fluids running, right?
So that ABG was on 10 and 80%. So now we're 18 and 100.
Ben is now alarming at you.
Okay. Can you tell me what our PEEP and plateau pressures are, please?
Peak is 50. Plateau is 45.
Okay. So given that those are closed,
Yeah.
tells me
Yeah.
that there's a compliance issue.
Take off of it.
Like it's probably not going to do it, but wait, this is so open, I'm going to take this off.
But if it's a compliance issue, would it be suction, right?
You can go ahead and try while I calculate this.
So run it down. I usually don't go all the way down. Also trace irritation and suction out. Did I get anything with suctioning? No?
Okay, let's go ahead and adjust our vent settings and chime in if you guys have any recommendations to a tidal volume of 350. And let's bring up the rate to 22. Given that our sats are 91, I think we can go ahead and leave the PEEP at 18, keep our FiO2 at 100,
Just a compliance issue.
and then can we get another follow-up ABG, please?
Okay, so our next one will be on those settings.
I'll practice.
And then can we cycle another blood pressure, please?
Your sats are up a little bit.
Do we think it's ours? Because if it's ours, we said, well, we want 88
Yes.
to 92.
Yeah.
And he's had an infection. He's got bilateral obesities.
And his plateau and peak pressures are pretty elevated.
Consistent. Okay.
Yeah. Our pressure stayed stable. We've started empiric antibiotics.
Fluid recess
I didn't-
and-
I don't know if we actually
I was
put
gonna
orders
say,
in that.
I was writing it down.
Okay.
So,
I'd like to consult with pharmacy about dosages, but I'd like to start on cephalosporin, fluconazole for fungal coverage, and then is there another one?
Like that.
Vanco. So Vanc, cephalosporin, and fluconazole.
which cephalosporin?
Sorry, cefepime.
Okay.
Thank you.
I don't know why it's coming out from you.
Peak
Thanks,
is,
Stephanie.
is longish because the peak is at 40.
Okay.
You can go back up on the rate again, drop the volume again. Because his low volume, I think, was 2 something.
Okay, so he's 5'6",
66 times.
66
It's 264, so you can take him down to 300 and see if we can't get his peak and stroke pressures down.
So
Yeah.
with 66 times, if we're doing the ARDS protocol, the 4 cc's per kilo, I got a tidal volume of 264.
That's the
Okay.
minimum.
The minimum. Okay.
And so
we-
we've correct, our pH looks really good on 22 and 350. So that's 7.7 minute ventilation. So if we dropped it to 300,
Getting a rate of 26.
yeah, that would keep you right there.
Okay. Let's go ahead and adjust our event settings to a rate of 26, tidal volume 300, and then we'll keep the peak and FiO2 the same, 100%, please.
Sats are okay, pressure's okay.
Colleen showed up late to her shift like she always does. She starts it most times. So she's showing up. She knows that there's something going on, but she hasn't fully heard, and she's going to take over for you. So would you mind signing up her and telling me what's going on?
Yes. So, hey, I have Mr. Patrick Johnson. We were called down to the ED. He's a 78-year-old male that's been having a 5-day history of some shortness of breath. We came down. He was satting in the low 80s, put him on a non-rebreather. We later made the decision to intubate him. His current settings are 26, 318, and 100%. We have some labs and an infectious workup. Took a look at him on ultrasound. Looks like he might have some hypertrophy in the left ventricle. Started fluids and we sent a couple ABGs as well while we were adjusting his vent settings. Do you have
So is he
any-
like sick or like should I go see him or?
Yeah, I would probably go take a look at him. Any other questions for me?
No, he sounds pretty